slips for membership application slips up front. So anyone else that would like to get a membership application to join the Academy, please see Ron Dressler, who's holding up those pink sheets back there, or orange sheets, whatever they are from here. Yeah, okay. And he'll get one to you, okay? I'm real pleased with the way the morning has gone, and I think we have a very exciting afternoon ahead of us, too. We have 3 more wonderful speakers, the first of which is Dr. Carolyn Tylenda. At our last annual meeting in Seattle, we were very fortunate to have a member from the Food and Drug Administration, Dr. Tom Callahan, come as to listen in on the meeting. And on the plane ride back with him, back to D.C., I mentioned to him that I would be hosting a meeting here, and in the May of the following year now, and thought that it would be wonderful if he or one of his people could come and talk to us, and because some of the questions that Mike brought up this morning were brought up at that meeting, and he thought some clarification could be made. So we're very fortunate today, and I'm very appreciative that Dr. Tylenda has made herself available on a weekend and during what is our local big dental meeting, which is the DC Dental Meeting, which is also this weekend downtown, which she has some commitments later this afternoon also. Dr. Tylenda has received her master's degree in chemistry, her DMD from the University of Pennsylvania, and a PhD in biochemistry from Georgetown, my alma mater, where her cousin was one of my professors, as a matter of fact. She is the Senior Regulatory Review Officer for the Dental Devices Branch of the Food and Drug Administration. She has served on the faculty of the University of Pittsburgh School of Dental Medicine and on the staff of the National Institute of Dental Research. She also has as one of her duties to coordinate the activities of Dental Products Panel and the FDA Consultant Base. Besides all that, she's in private practice like most of us. And again, I wanted to give you a warm welcome to Dr. Carolyn Tylenda.
Thank you. I'm pleased to be here today to speak to you on the regulation of medical devices by the Food and Drug Administration and the current status of dental amalgam. When I spoke with Dr. Fisher last week, he asked me to present some introductory material about FDA. FDA's mission, history, and procedures related to the regulation of dental devices, as well as to provide information on the current status of dental amalgam. FDA's involvement with device regulation dates back to May 28, 1976, when FDA first implemented the Medical Device Amendments to the Food, Drug, and Cosmetic Act. Prior to 1976, drugs and devices were regulated by the same component of FDA, what is now called CDER, the Center for Drug Evaluation and Research. In 1990, Congress passed the Medical Device Amendments to the Food, Drug, and Cosmetic Act. Congress passed the Safe Medical Devices Act. Oh, I'm sorry. On November 28, 1990, Congress passed the Safe Medical Devices Act of 1990. What I'm trying to say is there are 2 pieces of legislation that govern FDA's regulatory authority over dental devices. These are the May 28, 1976 Medical Device Amendments to the Food, Drug, and Cosmetic Act and the Safe Medical Devices Act of 1990. Dental devices are reviewed in the Dental Device Branch of FDA. To give you some perspective on where this branch is located within the infrastructure of the agency, the next few slides show the breakdown of the agency. FDA comprises 6 centers, which are the Center for Drug Evaluation and Research, or CDER, the Center for Biologics Evaluation and Research, CBER, the Center for Devices and Radiological Health, CDRH, the Center for Food Safety and Nutrition, CFSAN, the Center for Veterinary Medicine, CVM, and the National Center for Toxicological Research, NCTR. The last one is located in Alabama, the rest are in the Washington, D.C. area. CDRH is divided into offices. I'm not going to read through this entire list of offices, except to say that the dental device branch is located within the Office of Device Evaluation, which is in Yale. Another office you might be interested in knowing about is the Office of Compliance and Surveillance, OCS. This is the office within the center that is involved in compliance activities such as inspections and seizures. ODE is one of the larger offices within the center, and as its name indicates, is responsible for the evaluation of safety and effectiveness of device submissions for marketing clearance or approval. It consists of 5 divisions and several other components. The divisions are, for the most part, named for the devices for which they are responsible. For example, Division of Cardiovascular, Respiratory, and Neurological Devices is DCR&D. Divisions are further broken down into branches. The Dental Devices branch, DEDB, is part of the Division of General and Restorative Devices. Device submissions for most devices in a dental office are reviewed by the Dental Devices branch, but not all. For example, cotton gauze and swabs are regulated by the General Hospital Devices branch. Radiology equipment is regulated by one of the Radiology Devices branches. Sterilizers, dry heat, steam, glass beads are regulated by a relatively new branch, the Infection Control branch. Let me give you FDA's definition of a device. The term device means an instrument, machine, contrivance, implant, in vitro reagent, or other similar or related article, including any component, part, or accessory, which is 1, recognized in the official national formulary or the United States Pharmacopoeia or any supplement to them. 2, intended for use in the diagnosis of disease or other conditions, or in the cure, mitigation, treatment, or prevention of disease in man or other animals. Or 3, intended to affect the structure or any function of the body of man or other animals, and which does not achieve any of its principal and intended purposes through chemical action within or on the body of man or other animals, and which is not dependent upon being metabolized for the achievement of any of its principal and intended purposes. The 1976 Medical Device Amendment to the Food, Drug, and Cosmetic Act require FDA to classify all medical devices into one of 3 regulatory classes, class 1, 2, or 3, as I've listed here. Final classification of those medical devices that are considered to be dental devices was published in the Federal Register in 1987. The final rule on classification of dental devices can be found in volume 21 of the Code of Federal Regulations, Part 872. Each device is assigned a 4-digit number. For example, 21 CFR 872.6660 refers to porcelain powder for clinical use, and if you look up that number, you will find FDA's definition of that device. Class 1 devices are those for which it is felt that general control requirements will assure safety and effectiveness. And these general control devices are: first, adulteration. This refers to a device which is banned, which does not comply with the mandatory performance standard, or an investigational device exemption to which it is subject, or which is not manufactured in accordance with the device GMPs or good manufacturing practice requirements. Secondly, misbranding. This refers to a device manufactured in an unregistered establishment or whose advertisements and labeling do not comply with certain requirements for disclosure of product information if the device is restricted under Section 520E. This section defines restricted devices as those restricted to sale, distribution, or use only upon the written or oral authorization of a practitioner licensed to administer or use such device. Next, registration of each manufacturing location and listing of the devices with FDA. The Food, Drug, and Cosmetic Act requires manufacturers to register their establishments with FDA and to list their devices. Possession of a clear pre-market notification submission, also called a 510K, which I will discuss in a moment. Ban devices. FDA has the authority by regulation to ban any device intended for human use that presents a substantial deception or an unreasonable and substantial risk of injury or illness. Notification, repair, replacement, or refund. FDA may order manufacturers, importers, or distributors to repair or replace devices presenting unreasonable risk of substantial harm to public health so that the devices conform with the provision of Section 518B, or to refund the purchase price after affording opportunity for an informal hearing. And lastly, adherence to good manufacturing practices, which I'm not intending to discuss. If anyone's interested in those, there is a manual available from FDA. Examples of some Class 1 devices are a dental burr, a preformed crown, a porcelain tooth, and there are some other examples shown on this slide. Class 2 devices refers to those devices for which special controls may also be needed to assure safety and effectiveness. Special controls include performance standards, post-market surveillance, patient registries, development of guidelines and recommendations. Here are some examples of Class 2 devices. Temporary crown and bridge resins, impression materials, injection syringes, tooth shade resin material, and porcelain powder for clinical use. Some examples of Class 3 devices. In general, Class 3 devices in the dental area are due to new indications for use. For example, a dental laser for soft tissue use is a Class 2 device. A dental laser for hard tissue use is a Class 3 device. We have not yet approved any dental laser for hard tissue use. Class 3 devices are those for which insufficient information exists to assure that general controls and special controls will ensure that the device is both safe and effective. Class 3 devices require pre-market approval application, as was mentioned earlier. Prior to marketing a Class 1 or Class 2 device, a firm must submit a pre-market notification or 510K. The pre-market notification is referred to as a 510K because it is defined by Section 510K of the Medical Device Amendments. There is no application form, but rather a format which should be followed. 510K submissions should include the trade name, the common name, classification of the device, the establishment registration number, description of the device, drawings, photographs, diagrams, and specifications as appropriate, proposed labels and labeling, identification of all components, including flavoring and coloring agents for scent composition, claims and advertising material, identification of a predicate device for both composition and indications for use. A predicate device is one that was in commercial distribution prior to May 28, 1976, or has been cleared by FDA since that date. A statement as to how the device is substantially equivalent to the predicate device in both composition and intended use, and other safety and effectiveness information as appropriate. For example, we might ask for toxicity data. Substantial equivalence means that a device has the same intended use and the same technological characteristics as the predicate device, or has the same intended use and different technological characteristics, but it can be demonstrated that the device is as safe and effective as the predicate device and does not raise different questions regarding safety and effectiveness from the predicate device. Also required for a 510K submission is either 1, a summary of the safety and effectiveness information in the 510K, upon which an equivalence determination could be based. It's called a 510K summary. Or 2, a statement that safety and effectiveness information will be made available to anyone upon request. That is called a 510K statement. From the date of arrival at FDA, the agency by law has 90 days to review and make a decision on 510K submissions. The device will be determined to be SE, substantially equivalent, NSE, not substantially equivalent, or put on hold pending receipt of additional information requested by FDA. The company may not begin commercial distribution of the device until it receives a letter or order stating that the device has been found to be substantially equivalent. If, on the other hand, a determination of NSE is made, a PMA will be required. In the third case, additional information request, the file will be inactivated until the additional information is received from the firm in response to FDA's request. In order to market a Class 3 device, an FDA-approved pre-market approval application or PMA is required. A PMA is a major submission that includes technical sections, preclinical and clinical sections. When the PMA is received by FDA, it is assigned to a team leader who puts together a team to review the document. A team is a group of individuals with different areas of expertise and includes a statistician, could include a toxicologist, clinician, chemist, biomechanical engineer, and may include reviewers from FDA's consultant base, which I'll mention in a few minutes. The first step in review is a filing meeting, which is usually held within 45 days of receipt of the PMA. The purpose of the filing meeting is to determine if all the requirements for a PMA have been met. If there are major deficiencies, a non-filing letter will be sent to the applicant delineating the deficiencies. If filed, it is brought to panel within 180 days of receipt of the PMA. The panel may recommend approval, approval with modifications, or disapproval. The modifications may be whatever the panel feels is appropriate to ensure the safety and effectiveness of the device. It might consist of modification of claims, patient monitoring for a defined period of time, or labeling changes. FDA takes the panel's recommendation into consideration and makes a decision on approval or disapproval of the PMA. In a PMA, FDA is looking for clinical utility and sound scientific data that support the claims made for the product. Submissions will not be approved that do not provide valid scientific evidence of effectiveness and that do not clearly demonstrate clinical utility. Clinical utility can be interpreted to mean that the device provides a beneficial therapeutic effect, or for a diagnostic tool, that it provides information that measurably contributes to a diagnosis of disease or condition. It is not sufficient to establish that the device functions in accordance with its design. I mentioned earlier that a recommendation to FDA for approval or disapproval for a PMA is given by the Dental Products Panel. The Dental Products Panel consists of a group of experts selected from across the country to help FDA evaluate the safety and effectiveness of a new device. The panel meets at the request of FDA to review a PMA or for other reasons such as classification or reclassification of devices. The panel consists of 7 voting members, an industry representative and a consumer representative. FDA also has a consultant group which is composed of experts in various areas of clinical and basic research. The Dental Devices Panel is proactive in seeking out individuals with expertise who will assist FDA in evaluating the safety and effectiveness of dental devices. Dr. Fisher asked me to address several issues related specifically to dental amalgam. Let me address the first 3 together. One was, why has the FDA chosen not to classify or certify dental amalgam as a dental device? 2, why has the FDA classified the alloy for amalgam as a Class 2 device and dental mercury as a Class 1 dental device? And 3, since the FDA does not certify or classify mixed amalgam as a dental device, can dentists legally use it as an experimental dental device without permission from the FDA or without the patient's consent? In 1980, FDA proposed the classification of dental devices. It was proposed that dental amalgam would be considered as 2 devices, dental mercury and alloy, and that both would be Class 2. The Dental Products Panel, at that time called the Dental Devices Panel, reviewed the recommendations and recommended that dental mercury be placed in Class 1 and alloy in Class 2. As I mentioned earlier previously, in 1987, the final classification of dental devices was published in the Federal Register. FDA followed the panel's recommendation and placed dental mercury in Class 1 and alloy in Class 2. Dental mercury was defined as a device composed of mercury intended for use as a component of amalgam alloy in the restoration of a dental cavity or broken tooth. Amalgam alloy was defined as a device that consists of a metallic substance intended to be mixed with mercury to form filling material for treatments of dental caries. The reason for considering dental amalgam as 2 devices is that years ago many dentists were not using pre-encapsulated amalgam, and we had some manufacturers supplying mercury and others supplying alloy. It made sense from an administrative perspective to regulate amalgam as 2 devices. Today, of course, most dentists do use pre-encapsulated amalgam. Mercury was placed in Class 1 because general controls were judged to be adequate to regulate it. Mercury is an element. It was decided that USP-grade mercury would be the standard. The alloy would be Class 2 because the chemical formulation of the alloy can vary not only by percent composition, but by the types of metals used in the formulation. When a dentist uses a capsule of amalgam, he or she is simply using 2 devices. Dentists can legally use amalgam if both the mercury and the alloy components have 510K submissions cleared by FDA. Can dentists be legally punished for removing amalgam from a patient's mouth?
Excuse me, would you repeat that last statement?
Or did I make a mistake?
No, just want to... Didn't hear it well.
A dentist can legally use amalgam if both the mercury and the alloy components have 510K submissions cleared by FDA.
Has the last part still doesn't come true?
10K, is there 4?
The form.
Pre-market notification.
Okay.
Can dentists be legally punished for removing amalgam from a patient's mouth? At this time, the agency has not gotten involved in the practice of dentistry. FDA regulates dental devices, not the practice of dentistry or medicine. However, it is possible that FDA could become involved in the future. FDA is presently investigating physicians who are using injectable silicone. The material was not cleared or approved for the intended use for which it is being used. Earlier, I discussed misbranding. To repeat, Section 502 of the Medical Device Amendments provides that a misbranded device is one whose advertising and labeling do not comply with certain requirements of product information if the product is a restricted device. Labeling refers to the label plus any other written, printed, or graphic material that accompanies the device or that is placed on either the device or any of its wrappers or containers. Advertising may be considered to be labeling, especially if it accompanies the device, but also sometimes when it does not. Dentists who advertise are responsible for the material in their advertisements, and they must be able to substantiate all claims that are made. The Federal Trade Commission has the primary responsibility for regulating the truth or falsity of medical device advertising statements other than labeling. However, if advertising is determined to be labeling, then FDA has primary responsibility. If FDA interprets that a dentist has misbranded a device or a class of devices, then FDA could consider taking action. And the next question was, in view of the fact that EPA and OSHA have both designated mixed amalgam to be a toxic waste disposal hazard, is there any phenomenon which could account for its being safe when implanted into a person's mouth? Clearly, the issue of safety of dental amalgam is not resolved. For FDA to make changes in the regulatory status of amalgam, a body of knowledge is required that clearly establishes that mercury vapor from dental amalgam poses a health hazard and defines those hazards. Safety is an open issue with FDA. We always welcome new information related to safety issues of regulated devices. As many of you recall, in March of 1991, FDA held a dental products panel meeting to discuss dental amalgam. We searched scientific databases and supplied the panel members with a large amount of literature to review. We made great efforts to invite speakers from around the world who we believe were leading authorities in the area of mercury toxicity, and we asked them to present results from scientific studies that would define the hazards of mercury vapor from dental amalgams. The panel listened to the presentations and unanimously agreed that there was insufficient scientific documentation of toxic effects to humans from mercury vapor from dental amalgams to warrant change in the regulatory status of dental amalgam. The panel was impressed by the number of anecdotal case reports related to toxicity from dental amalgam and urged that scientific study be undertaken to definitively answer the question. FDA has followed the panel's recommendation and made no change in the regulatory status. In the meantime, as part of the process of regulatory management, FDA is in the process of reviewing current labeling for dental amalgam. On another topic, many of you may be familiar with CSER, which stands for the Coordinating Committee on Environmental Health and Related Programs. This is a committee headed by Dr. James Mason. The committee is, at the present time, evaluating dental amalgam. 3 subcommittees of that committee have been active in this process. The Benefits Subcommittee and the Risk Subcommittee have met and developed reports. Let me change that. The Benefits Subcommittee and the Risk Assessment Subcommittee have met and developed reports. The Risk Management Subcommittee, which has the task of evaluating and merging the other 2 subcommittee reports and developing management strategy, is in the process of finalizing its report. This final report is expected to be completed and forwarded to Dr. Mason sometime this summer, certainly by the end of the fiscal year. Dr. Mason and CSER will determine what action should be taken. Included in the report will be a list of recommendations for research directions that are considered to be crucial in providing answers to key questions on the amalgam mercury vapor issue. Let me add that FDA has the lead on this 3rd subcommittee, the Risk Management Subcommittee. FDA strongly hopes that the scientific research community will use this list of research topics as a guideline in developing new research protocols on dental amalgam and mercury toxicity. And the final question was, we would appreciate some comment regarding the mounting number of reports of adverse reaction to dental amalgam being filed with the FDA. FDA has created a database on the reports of adverse reactions to dental amalgam. The database is reviewed periodically by the Dental Amalgam Task Force. The database has been scanned for a number of parameters, including gender, age, and commonality of complaints. While these reports have some value, there is a limit to the information that can be gleaned from them. as I'm sure all of you recognize, these are testimonials and cannot substitute for well-designed scientific studies. Recently, FDA has sent letters to the submitters of each of these reports, asking for their permission for FDA to speak to their dentist and or their physician. We hope to determine if additional information is available that might be helpful to us. For example, if medical tests were conducted prior to and post removal of amalgam, or if there is a family history of amalgam sensitivity. I hope that my presentation has been helpful in clarifying some of the regulatory procedures at FDA and in clarifying the present status of dental amalgam. Thank you. I'd be happy to answer any questions.
I just want to make one announcement to the group, and again, thank Dr. Tylenda for being here. She does have a speaking engagement at the DC Dental meeting later this afternoon, so she would rather take questions now because she's not going to be able to stay late to our panel discussion. So we'll take questions.
As I understand from your presentation, the dental amalgam probably falls under what you would call predicated dental device, which in lay terms would be what we call grandfathered.
Yes, the 510K is essentially a grandfather clause.
Okay. It was my understanding that that was no longer going to be allowed as of 1977. That further grandfathering was strictly forbidden by the Congress.
No, that's not correct. And in fact, the latest act, which is the safe, it's a Safe Medical Devices Act of 1990, the second piece of legislation. Actually, what it does is it codifies many of the existing practices at FDA, and it states that a predicate device does not have to be one that was on the market prior to May 28, 1976, but it could be one that was cleared by FDA after that date.
On that same, the follow-up on that same kind of question, there are two types of amalgam. One is non-gamma 2, and the other is the gamma 2. In Germany recently, the Department of Health their FDA banned the gamma 2 amalgam, and stating specifically that their reason was that the release of mercury vapor from the restoration was hazardous to the patient. What is the status of the FDA on the difference between the non-gamma 2 and the gamma 2 amalgams, and is the release of mercury vapor not hazardous in the United States and hazardous in Germany?
We don't differentiate different types of amalgam at this time. And as far as the toxicity of the mercury vapor, we need to have a body of scientific evidence before we would take any action.
Other than the EPA and the World Health Organization documents?
Well, we had a panel meeting last year in 1991, and all the information was presented to that panel that was available at that time. The panel recommended that there was not a sufficient body of knowledge. And until we have that body of knowledge, we do not have enough information to say that the mercury vapor is toxic to humans.
And the only last question I have is, since dental amalgam is a type 3 device by the regulation, as I understand it, it's an implant, and you have to have evidence of safety of implants before pre-market approval. Is that correct?
No, dental amalgam is considered to be a class 1 and class 2. It's actually 2 devices. It's not a class 3.
I believe that in the definition that an implant is any...
FDA does not consider dental amalgam to be an implant.
So it's not an implant. Good.
Right, according to FDA definitions. A temporomandibular joint implant would be a class 3 device.
Doctor, regarding the letter that FDA has sent in response to the adverse reactions forms that patients have sent in, a number of my patients have called me with some concern about giving this information out in response. They are, I would say kindly, somewhat cynical and skeptical of how the information would be used, especially in light of about a week and a half ago, one of the most respected alternative health care physicians in my area Dr. Jonathan Wright had his office raided by the agents of the FDA, breaking down his door, coming in with flak jackets and at gunpoint. So my patients are understandably concerned about how this information would be used. What could you advise me to advise them that would assure them of how this information would be beneficial to the FDA?
What I can say to you is that FDA is very careful about confidentiality. The only information that can be released from FDA has to be released under the Freedom of Information Act. And a written request has to be made that information is not freely given out. Any material that is asked for is very carefully reviewed by the office trained in that area to remove any confidential information.
At gunpoint with black jackets?
Well, I don't think anyone comes into the Freedom of Information office with flak jackets.
That's our concern.
The patient's concern.
Well, I think you should understand that I'm not in the compliance area. The information I gave you regarding compliance, I acquired from the compliance branch. I made phone calls to them. The FDA is a large organization. There are more than 5,000 people, and these offices are very large. So, I can't account for every FDA action. I can't answer every single question. I came to give you information on the procedural aspects of FDA regulatory authority and to give to the FDA view of the current status of dental amalgam within FDA.
Could you just repeat again how the information is going to be used that comes in from these letters?
The information would be reviewed by the Dental Amalgam Task Force to determine if there is any, if there were medical evaluations done prior to and post removal of amalgam, so that we can get a better handle on relating the symptoms to the removal of amalgam.
Based on what you...
Because we would certainly never publish anyone's name if that's what you're
No, they weren't
concerned
concerned about names being published. They were concerned about the physicians that they have worked with having their offices broken into, being physicians practicing alternative medicine. They didn't want their doctors to get in trouble by having their names given.
I see. I can understand your concern. Truthfully, when we wrote that letter, we were really looking for more information. I mean, we hear so many anecdotal reports about problems, but FDA can't take action until it has its body of knowledge, and that was our intent. The intent, I can assure you, because I'm on the Dental Amalgam Task Force, no one ever considered raiding anyone's office. And this is not a group, as I say, FDA is huge. This is not a group involved in any sort of activity such as that. This is a group involved in evaluation of data.
Based on the information you've been exposed to over the past few months, few years being with the FDA, knowing there is a controversy, and hearing some of what you heard this morning from Dr. Sith and others, have you formed any personal feelings, changes as far as where we're at? How do you feel about it personally?
I am here as an FDA representative, so I don't think it's appropriate for me to give my personal views. What I can say is I found this meeting very interesting, and I will take back what I learned to FDA.
I'm a little bit confused about the Class 1 and Class 2 classification. My understanding from what I learned this morning is that basically Class 1 devices are those which are essentially non-toxic. Class 2 have some degree of toxicity, and Class 3 there's a considerable issue about their toxicity or safety. Am I correct up to this point in that?
Well, Class 1 are those for which general controls, that FDA can feel sure that general controls can be used to assure that they are safe and effective. And Class 2, special controls may be needed to assure safety and effectiveness. For example, as I mentioned, patient registries and so forth.
Could you further clarify for me briefly what is meant by general controls, and then I can ask the question of you.
Oh, well, maybe we could go back to that slide.
Would you like to back on
Mhm,
the slide? Okay, well, already.
Oh, well, let me see, I think I have general controls. General controls, there are 6. Here we go. Adulteration, misbranding, registration of each manufacturing location and listing of the device with FDA, possession of a cleared pre-market notification submission of 510K, ban devices, which means FDA can ban a device, notification, repair, replacement, or refund.
Now, you're saying that general controls are designed to make sure the product is safe and effective. Most of us here would, I think, would agree that mercury is not safe in any form, really. And the impression that I'm getting is that it's been classified as a Class 1 device simply because it's a pure compound and for no other reason. And I guess what I'm asking you is how, given the parameters that you have there for safety and effectiveness under these general controls, how did mercury get it to become classified as Class 1? Frankly, it doesn't make sense to me.
When a device is cleared by FDA for marketing, the device is cleared only for a particular indication for use. The indication for use for dental mercury is only in dental amalgam. So the danger, FDA does not, as I mentioned earlier, regulate dental offices. So if, as far as mercury vapor from amalgamators, occupational exposure, that's under OSHA. We regulate only the device. The dental mercury that we have cleared for marketing is only for use with dental alloy to form dental amalgam. When dental amalgam is placed in the oral cavity, we realize that there is a small amount of vapor over those dental amalgams. But the situation is that there is not enough scientific knowledge, not enough valid documented science to unequivocally establish that small amount of vapor is causing a problem in humans. And if that is a problem, then certainly we would like to see that data.
Don't you recognize animal data?
Animal data is useful, but it's useful only to a certain extent.
Thank you for coming. My question deals with the last paragraph under definition of device, that there's no changes once the device is used within the human body. Am I interpreting that right?
Well,
Because dental amalgam undergoes constant change.
which does not achieve any of its principal intended purposes through chemical action. I think what we're talking about, we're talking about, say, biological molecules that would have, say, growth-enhancing properties once placed.
But that definition states, which does not achieve any of its principal intended purposes through chemical action within the body. And dental amalgam constantly undergoes chemical change. So that part of your definition is incorrect. Or amalgam is not a device, the way I view it. I appreciate a response.
Well, I can't give you a response except to tell you that we do consider amalgam to be a device.
I'm a non-dentist. In '90, after suffering for well over a decade in mental hospitals without a diagnosis that at all described the problems or what was causing the problems, my wife and I prepared for my death. We worked up my will. I was so sick. If it had not been for a 60 Minutes program that I by chance happened to see, I'm convinced I would not have lived through 91. I did not anticipate to live half through 91. I nearly died in the mid-80s. This time I did not believe I could make another round like this. If it had not been the amalgam, I would not be standing here today. If the amalgam removal had not solved the fundamental problem with my body, I would be dead today. Now to you, I know that's anecdotal. I know there's an issue of scientific versus anecdotal, and it really ultimately comes to an epistemological problem that many people in science have, an inadequate conception of what are valid sources for knowing. Scientific evidence isn't evidence that humans suffer, because you can't perform scientific evidences or research on humans with this product. It's too dangerous, and everyone knows it. So the only place you can get information about humans that are suffering is, quote, anecdotal. There is scientific evidence on animals, but evidently it's not considered sufficient. If the ADA had its way, I would be dead now. My two children, the oldest of which is 8, and the youngest is 4, would have a dead father. My wife, who loves me very much, had to steel herself from the time of our marriage. I was down to 135 pounds when we got married 10 years ago. For the eventual potential death of her husband, by some cause we had no idea. All we knew is my health. The symptoms were killing me. The ADA has caused dentists to believe that they should not mention to patients that there is any potential problem with amalgam, or that they're even implanting mercury in our bodies. I could not even drink spring water. I would get out of a spring myself. I could not drink tap water. The immunologist that I was going to, who had a PhD besides his MD, would not mention it to me, that I had mercury being released in my body. It was only after seeing that program. Does the FDA have the power to serve the interest of the public? What I saw today in classifying mercury as class 1, I consider it criminal. And that was not just a criminal act by the ADA, but by the FDA. I consider it criminal. These dentists aren't going to say that, but I'll tell you to your face, that's criminal. And it doesn't take a dentist to see that. It's insane. I read the dental journals, and they talk about dental implants, but you define it as a non-implant. It's absurd. I'll say one more thing, and then I want to know, can the ADA do to require the dentists of America to do the same thing that doctors are required to, and say, this is an implant, or this product that we're placing in your body, although implanting in your body, although it is not an implant, contains mercury that can be released, and mercury is known to be dangerous. And second, the last time I went to a barber shop, my 4-year-old boy went with me. At the barber shop, people would say to him how they had children like him back home, or a son that had been like him, and he would ask them, did he die? Now that sounds morbid for a 4-year-old to be asking strangers. The barber couldn't figure out why. I had to tell him, that his daddy almost died on him last year, and he thinks anybody that's dear to anyone dies on him. I consider your organization has failed me, has failed my family, and has failed tens of thousands and millions of other people in this country. And you've been serving the ADA and not maybe realizing the implications behind it.
I appreciate you sharing the information with us. I'll certainly take that information back. I'm very sorry to hear about your health problems.
That's what Dr. Van said at the ADA. He's sorry. But you nearly killed me. And you're just as responsible, or more so, than the ADA.
Doctor, I submit with these letters that I'm giving out here, and I've sent to the FDA Commissioner, that there is a confidentiality problem within the FDA at the highest level in the office of the Commissioner, because I sent my first letter alleging fraud, internal deception, intentional deception, conflict of interest in this letter. And this letter did not go to Special Agent Hubbard and the Division for Investigation and Program Integrity. It was published to everyone in the agency, evidently of at a certain level, other than them. And I list those people in the second paragraph of the second letter that I sent, that I had to send special certified, send it Federal Express to make sure the Commissioner could get a letter to see from me to him directly, hand-delivered by this agent. And so I submit to you that there is definitely a confidentiality problem, because I found out that evidently, I don't know if you've ever seen this letter before or not, but that this letter went to the Center for Devices, to your center, and to certain people in that center, and possibly even to Dr. Singleton, who I had complained about in this letter. I understand from the facts that there is an investigation underway of that dental device division. This probably not news to you, but it should also not be news to you that, because you were at the FDA hearing a year ago where I testified to, that I submitted a copy of a body of evidence, a body of data, okay, to that panel, showing, I didn't have in my hand, I didn't have at that time what I have in my hand now, which is the final report of the Olin chemical mercury spill, the EPA Superfund cleanup site that occurred, of which I'm more than happy to give you a copy of. But in it, they found levels of anywhere from 1 to 5 micrograms per cubic meter of mercury in the carpet in the homes of the workers that had tracked that mercury on their shoes back to their homes, even in the carpets around the children's bed in those homes. EPA Superfund in those homes required the carpets to be ripped up at levels of 1 to 5, like David Smith, the attorney from Nashville, testified at that meeting. This is what the report he was speaking of, 1 to 5. And over a year ago, I submitted to the FDA the results of the tabulations that I've got of before chewing and after chewing of 15 before, for an average of about 50 people, to an average of 70 after chewing. These are micrograms per cubic meter using the exact same machine that was used to get these other instantaneous readings in the homes, in the carpet. So as you can see, this is significantly higher levels of mercury contamination in the mouths, in the microenvironments of 50 of my patients 2 years ago. If the EPA is so concerned to rip up carpets at 1 to 5, what will it take for the FDA to be concerned enough about the health of our patients to accept some, I understand this is raw data, but anyone could have done this who has machines. What is it going to take? How high a levels do you want to see? I've seen patients 200 last night.
I can't give you an answer and give you a number. What I can say is that, as I mentioned earlier, when the CSERP report comes out, there will be a list of research objectives, and that's the kind of data we would like to see. The data from the studies listed in that report. I'm sure when it comes out, it will be publicly available. But I can't stand here and address every piece of scientific literature and every piece of data that somebody gives us. It's not, I'm not prepared to do that.
Oh, I understand. I just don't understand. If it's been a year, you know, I don't know how high. If the EPA is concerned at 1 to 5, and the FDA is not concerned from 15 to 70, it seems incongruous.
Doctor, I was wondering, you mentioned something about you're reviewing current labeling on amalgam. Could you tell me what that's a reference to?
I really would prefer not to develop that topic.
Okay, you also mentioned that there's a benefit committee and a risk management committee and another committee.
Subcommittee.
There are toxicologists and pathologists and MDs on those committees?
Let me think. Yes.
Okay, thank you.
Your last question.
In Dr. Ziv's presentation earlier, I'm not sure if you were here for that entire presentation, but
Yes, I was.
he offered a definition of an implant, as I understood it, that was given in one of the FDA regulations. And yet you have, and he suggested that by definition of that implant, that amalgam would fall into that, yet you say that the FDA has not put amalgam into that definition.
Excuse me, the FDA commissioner ruled that it did fall into.
Yes. Can you clear up the difference that I'm hearing from Dr. Ziv's presentation and what you stated that amalgam is not considered to be an implant? Why?
No, I really can't, because I wasn't involved at the time that decision was made. I know the way we handle amalgam today, and have always handled amalgam, and that it is not considered an implant. But I was not involved in the discussions on why.
I mean, that seems to be a very crucial element to this whole process. And if you can't answer it, I think this organization and perhaps many others would...
Well, I could answer it if I had known you were going to ask this question, I would have found out that information, presented it to you. But I don't want to give you an answer at the top of my head and guess and surmise, because I'm not here to do that. I'm here to give you fact. If I can't give you exact fact, I'd rather not comment.
Well, I think we respect that. Is it possible to have an answer provided to us?
Might I propose, since we're local, that maybe this is the beginning of some dialogue that I think is very important to keep open between the FDA and we and us in the Academy. And maybe you can check into that and let me know, and I can distribute that information
Well,
to...
perhaps you could send us a letter and specify exactly your question in writing.
Okay. Yep. Fair enough. Good. Thanks again. I appreciate the participation of Dr. Tylenda and taking time out of her busy weekend to come be with us today. And I do mean that very sincerely, that starting with last September's meeting when Dr. Callahan came to listen in, and now with Dr. Tylenda participating in this, I really anticipate better dialogue and better exchange of information to continue on this and other issues. Okay, our next speaker is one of our own, Dr. David Kennedy, who's our Executive Vice President, and comes all the way from San Diego. Those of you who haven't heard Dr. Kennedy speak before, I think we're in for a great treat. We all enjoy the fastest mouth in the West, and it's my pleasure to introduce Dr. Dave Kennedy. Thank you, sir.
Again. I mean, before the Academy again. And I know that the regulatory bodies of our government do have a lot to do and a lot on their minds. And so does the President of the United States. And recently, George had a chance to travel to Japan to let the the other countries know that we're not pleased with all the Hondas and Toyotas we see. And maybe they could give us a loan or something. And an unfortunate incident occurred while he was there. He threw up and passed out. Damn, I hate it when that happens. Yeah, but you know what they did is they immediately passed it off and said, well, the doctor gave him a little sleeping pill to help him get over his jet lag. I didn't know sleeping pills helped with jet lag. But anyway, the sleeping pill was by the name of Halcyon, and I got this thing in the mail right before I came out here. It came from the FDA. You're probably familiar with those people. And I had to read this, and as I got to reading it, I thought, you know, this is just the kind of drug that I want my president to be on. And, well, you know, they don't have much else to do, so they might as well get high and do this stuff. I'm from California. Anyway, apparently somebody wasn't too terribly pleased with his response to that anti-jet lag drug. And so what it said was shortly thereafter, the FDA has decided to revise the labeling and emphasize that the drug is indicated only for short-term use, and that if you got to use it more in a couple of weeks, you better get a full physical, and that the effects appear to be dose-related. And those effects, as enumerated in the FDA bulletin, are abnormal thinking and behavior changes. They have been reported on association with the use of this hypnotic, including Halcyon. The changes include a decreased inhibition, such as the excessive aggressive behavior and extroversion similar to imbibing excess amounts of alcohol, agitation, hallucination, depersonalization, and a worsening of depression. It didn't say anything about throwing up. Well, anyway, that's what I want my president to be on. But you know, you can get action. All you got to do is know the right people and bark on them. Anyway, I thought you'd like to see that can happen. Hit the slides. We're ready to go.
You hit them. You're on.
Oh, gee. Which one? This one?
Yeah, use the
All right.
right.
Okay.
Use it once.
Forward. All right. Okay, now hit the lights. So on a number of occasions, I've been allowed to present this compilation of a number of scientific papers. There are about 160 references in the article. We just recently got back from a quick trip to Brazil and had a really enjoyable experience there because Dr. Pinto bribed the dental school to send over about 4 people for slaughter. And, for debate. And that what they did is they took the same information and said, see all this excessive exposure of dentists? There's no problem. And then I got to show all the infertility and birth defects. Oh, damn. Let's see if the second one's just as bad. No, that's pretty good. Mercury's not the only thing in our environment in the dental office that is a problem. There are a number of things that we're exposed to in the dental office. I'm going to focus on mercury for the purpose of this presentation, but let me assure you that if you have a Harvey Vaposterol or you're using germicides in your office, you're exposed to formaldehyde, phenols. 70% of the crowns placed in Americans' mouths last year contain nickel, and bridges also, which is a known carcinogen. It was one of the first metals ever regulated in the history of the United States. Acrylic monomer's not that good. A lot of dentists develop allergic reactions to that and can't practice. People get the sore mouth and so forth. And then we also had a nice debate down there about fluoride, which is now ruled an equivocal carcinogen. I'm going to have to fix that. Let me check one more thing. No, I'm okay. Let's not worry about it. How toxic is mercury? When you rule on toxicity and you look at it, basically mercury is more toxic than arsenic and lead. On a scale of 1 to 2,000, plutonium is 1,600. Elemental mercury vapor is, plutonium is 1,900. Elemental mercury vapor is 1,600, and lead is 900. So, you know, there's really no question that we're dealing with an extremely toxic substance. So, if I were to go forward, will I lose Dave Reggiani's finger? No.
Did you put arsenic in there?
Arsenic was there. I don't know the number on arsenic. I think it's higher than lead. I think it's around, I'm going to guess 1,100, but I'm not... because it was different formulas. They had different breakdown products. The reason that arsenic appeared in all 3 columns. But,
Want to go back?
Yeah, I'll go back one. Arsenic appeared in the left column, the middle column, and the right column, and that's actually a slide that I've made from a study where they exposed chick embryos to those various compounds, and the arsenic in different forms exhibited different levels of toxicity. And
I know that the Friday has
absolutely. And so what we're really showing there is that there are, severely toxic. You got mercury, arsenic, cadmium, and Vanadix tin. On a scale of, just to bring you into perspective, many dentists, this is kind of, one part of the lecture is really to kind of blow away some of the stuff that I was taught in dental school. Because I was taught in dental school that the liquid mercury is no problem at all, which is probably true. But it doesn't stay liquid. It comes out in vapor form, it oxidizes, turns to mercury oxide, et cetera, et cetera. So when you look at mercury per se, the element, Hg, once it gets in the body, is one of the most toxic things known to mankind. And that's the real purpose of the slide. The EPA has agreed with that and said no amount of exposure to mercury can be considered totally harmless. You've heard that before. The EPA developed a daily intake standard, and this is they allowed 20 micrograms to come from air, 10 to come from sources other than air, and a total of 30 overall. What's interesting in that slide is that they specifically allocated 20 to be set aside for the air we breathe. So that's air pollution. Okay, and so dietary sources, medicines, and sources other than air are limited to 10 micrograms according to our EPA standard. It is a neurological poison. When you look at the pattern of diseases, the question came up earlier, what are the symptoms of mercury poisoning? When you look at the pattern of symptoms that you get from mercury, most of the symptoms, by far and away the majority of them, in the earliest part of the disease have to do with the way the brain functions. Well, like for instance, depression. What is that? Well, if you're not taking Halcyon, it's basically a lowering of your self-esteem or your present attitude or something like that. But how are you going to put a hook on depression? We got a whole profession set up to treat it. But yet it's one of the most common neurological problems often found in dentists. Kill themselves twice as often as the average American. And yet it's not really something you can put a label on. Well, you've got 4 parts per million depression. So neurological damage is something that we're going to look at in just a second. And immunological damage is something we can get a handle on. We can look at the decrease in the white blood cells, the inability to chemotax toward an infection, et cetera, et cetera. And then endocrine is the dysfunction of the hormone system, and one of the most sensitive biological monitors of the endocrine system is reproduction and a woman's menstrual cycle. So we'll look at that a little bit in terms of dental personnel. One of the things you often hear is, well, if this was such a problem, wouldn't we see it in dentists? And well, yes, that's true. And so let's go look. In the immunological problems, we've shown through scientific experiments, and these are animals again, the basically immunological symptoms of mercury exposure are a decrease in the migratory factor. And so white blood cells don't go toward antigens. They develop anti-nuclear antibodies. Anti-nuclear antibodies means that you can get an immune response to your own cell nucleus. Matter of fact, if they want to create autoimmune diseases, they expose the rat to mercury, and then the rat develops an immune response to its own body. It inhibits what's called the respiratory burst. And if you think of a white blood cell as kind of like Darth Vader, he can drop around himself hydrogen peroxide or oxygen, which is a respiratory burst, to kill bacteria. So they march along like the Roman army, and when they get close to an infection or something like that, they spew out around them a respiratory burst of antibacterial substance. And if you have mercury in there, it's kind of like Darth Vader with no bullets. So that's not considered real cool. It does develop an allergic reaction. Your body can form an immune response to the metals. T-cell suppression has been demonstrated to occur, and that both an increase and a decrease in white blood cells. Why is that significant? Is it when you put amalgams in, you immediately get an up and then followed by a down? Well, why is it significant? It means that when you're doing something in the mouth, you're having a systemic effect, and that means you can't work on the teeth without physiological response. And that's the thing that dentists have to understand. We're not tooth carpenters if we're implanting substances that have a systemic effect. And so I know that Dr. Tylenda had to run, but I think I really do agree with my talk, is that when you put something in the mouth that has a systemic effect, aren't you really dealing with a drug? Exposure sources. In measuring dentists' offices, they've come up with a number of different ways to do that. And this is something that's useful for anybody in this room that is still using mercury or even removing mercury, is that you can purchase what's called a passive exposure badge. And basically it's like your x-ray badge, just hangs on your pocket, hangs on your assistant's pocket. You can wear this around. And that wherever you happen to go that day in the office, or that week, or that month, or however long period of time you're wearing the badge, it will measure how much air that has mercury contamination in it that you pass through. Then you send this in and have it analyzed to see what the contamination level that you were exposed to. And that this was in England, a fairly recent study. They found that out of 704 surgeries, 10% of the people turning their badges back in had been exposed to excessive amounts. Phil?
What do they consider surgeries?
Surgeries is their word for operatory. Drillers, 704 surgeries is like if one dentist had 3 operatories, that went down to 3. Okay? And so I put the line here on this graph. From a couple of studies that were done about how much mercury comes off the filling or in the dental office from various places during various procedures. As you can see, that the 2000 or 2000 plus, I should add, is drilling high dry. And that means that if your high-speed turbine touches a tooth, that you're going to get some hellacious amounts, stupendous amounts of mercury off of those teeth. The University of Pacific School of Dentistry, where our next meeting is going to be held right near there, many of their former students or friends of mine in San Diego have explained to me that before they moved to the new school where they had running water, they used to teach the students to drill out high drive because they didn't have any high volume suction. So they just said, well, you can just go ahead and drill on it. So up until about 7-8 years ago, we actually had dental schools in California teaching students to expose themselves, their patients, and everyone in the clinic to levels that are 200 times higher than California would allow the school to be. So when Dr. Tylenda wants to have more data, I can understand why. Because once you've been exposed to those levels, it's really difficult to think. In the top one, the spittoon, here we have a material that once the dentist has mixed it up, there's only 2 safe places to dispose of it. If you spit it in the sink, then they've got to catch it a trap and send it to a hazardous waste recycler. So the dentists I know that don't want to spend all that money on hazardous waste recyclers, they just say swallow, swallow. So this is an effective way of reducing your liability in terms of hazardous waste disposal dumps. The oral aspirator, this was a particular study done in England where the aspirator was vented inside the office. And as we're talking about putting these little traps and so forth that catch the mercury coming out of the sewer and so forth, one of the problems is you got to make darn sure that the exhaust does not exhaust anywhere near anybody that you want to continue to prosper and live well. Because the stuff coming out of the air coming out of the back end of your turbine is your suction equipment is fairly toxic, and this was an oral evacuator, very common in England, I'm told. And so Wayne King demonstrated for the panel there in Washington that when you mix the amalgam, that you can not only destroy your Jerome 411 mercury sniffer, but you can achieve levels that are similar to the high dry when you open the capsule. So, autoclaving, this is just an ordinary autoclave. I have an autoclave that hasn't had amalgam instruments in it for 10 years, and I ran it after I saw that slide a few years ago. I ran my Jerome 411 around the autoclave a time or two, and darn if it didn't still have 4 or 5 micrograms of mercury inside the chamber some 10 years after the last time it had amalgam in there. Do you think it may be saturated? Well, we built a hood over it, so I can't throw that thing away. It's still working. So packing it in by hand or with the mechanical instrument, the mechanical instruments release a lot more mercury than by hand. So the point that I want to make to you is that just because you're mercury-free does not mean you're not going to be exposed to mercury. Our patients have little bombs in their teeth, and if we're going to be in the process of taking these things out, we've got to realize that we're going to be exposing ourselves, our staff, and everybody in the vicinity of our dental office, including the garbage man if he's standing out around your vacuum, to levels of mercury that are considered hazardous by most normal thinking people. In surveying dental offices, and this we alluded to earlier when we were talking about the EPA, this is Dr. Kennedy's compilation of 6 different studies. In my article, I give you the references, but you can see, depending on the sampling technique and the location in the country, we found that the varying between a high of around 16% down to a low of around 4% of the offices exceeded continuously the hazardous waste disposal dump standard, and that the ADA would like to use the hazardous waste disposal dump OSHA standard as the norm, but in California we have a thing called Prop 65. And the Prop 65 says that if you're going to expose somebody to a material that is known to be a carcinogen, you need to display that poster on the front door of your establishment. So when you walk into a bar in San Diego or San Francisco or wherever, it says, by the way, there's folks in here smoking. And if you're pregnant, you can have a funny-looking kid, so watch out. And they're going to be serving alcoholic beverages, so, you know, if you're pregnant, don't come in here. And by the way, if you want to pump your own gas, you better get the attendant to do it because, you know, you might have a birth defect kid or cancer. And this was passed a number of years ago. What's interesting is, at least according to this graph, a minimum of 16% of the offices should have that poster on the outside for OSHA standard. Prop 65 is based on EPA standards. So if we really wanted to bother dentists, any dentist putting amalgam in must display that poster on his front door. And I tried to tag no, I've never been known to be real quiet, but I tried to tag UCLA. I took a course there, and they had fairly decent levels of mercury vapor around a couple of their amalgamators. And I sent a letter to the dean of UCLA and said I thought maybe he illegally exposed me to mercury vapor, and he said he thought I'd illegally measured his clinic. And I said I wasn't really familiar with how it was that, you know, that you couldn't measure a place where you were a guest, and paid to take a course. And so we agreed to disagree, and I said, where's your Prop 65? And fortunately, the attorneys for UCLA found that there was a loophole in 65. Government office buildings and schools don't have to comply with Prop 65, but they do have to comply with the EPA standard, and they never answered that one, so I let them go. I got tired of playing with them. Figured they'd probably knock down my door real soon. So anyway, because I illegally measured the clinic. When you look at urine levels, what we've decided to do is become orthodontists. Because we just talked earlier that urine levels are not, you can't correlate urine levels to your exposure very well. But if you take a large enough sample, it can tell you something about the exposure if it's a large sample. And the reason this doesn't work is that in studies of workers, like for instance, women who took a new job at a factory where they were using mercury, initially ran a high urine level, and over the next 6 months their urine level declined. Well, did they get exposed to less? No, their kidney gave out. So the people that are lowest in their urine level are probably the sickest. So this was measured on dentists. There were very few controls on the way it was measured. It's a very lousy study. But what it does show is that depending on what you do for a living, you get more. And since there's a lot of general dentists that do amalgams for a living or remove amalgams for a living, they would fall into that last category down there at 16. There's no agreement that 16 is bad for you, but it's higher than the sheet that Murray showed that the kidneys were failing, so I don't think it's probably real good. And then they took that same data and grounded it another way, and they showed that you ran higher the more hours of the week you worked. And so what we've decided to do is take more time off. And I love this study because this was a Navy study. Right here in Bethesda, as a matter of fact, they had a circular clinic, and the guy on the left-hand side was the fellow closest to the amalgamator. Well, you know, the Navy, they're real conservative with your dollars. You know, they'll buy $1 million toilet and won't buy a $2 amalgamator. But so the clinic, all these people in this clinic had one amalgamator. Well, you can imagine with that many drillers how often that amalgamator is running, you know, like every instant of the day. And the poor guy sitting right next to it got a real good nose. Well, the captain was the one next to it, so I guess that's fair. Anyway, so the lieutenants are the guys they put clear back in the corner. So But he also noticed their assistants were high also. And that assistant probably was a little lower because they had to run around and drink coffee and hide out. So I was in the Navy. We hardly ever saw our assistant. But anyway, the patient exposure is exposed through a number of ways. They get it from their mouth, they get it from nasal tissue, they get it from their intestines, and they get it absorption through the gum tissue. We've kind of beat that one to death. So Dr. Vimy showed that just chewing, and Dr. Savary showed just chewing, and Dr. Stock showed half a century ago that mercury came out, and that when you slice the sheep up, you know, it was in just about every little piece of tissue you could find, especially around the teeth that we kind of hoped would stay in. In the brain, we were talking about neurological problems, so, you know, gee, let's look at the brain. And so we've got 3 people that have looked at the brain pretty extensively, and then one of the interesting experiments was done clear back in around World War II time. Dr. Stock was the head of the German Chemical Society, and the lady had exposure right before death, and post-mortem showed that most of the mercury went to her pituitary. Very interesting, because that exposure ending up in the pituitary really should have been a clue that what we're really looking at in terms of brain damage is some of the endocrine function that pituitary is controlling. It's the master controller. Stodebeker followed up on a dog study where the dog was allowed to breathe, and that interesting enough that the blood level never really got very high, and that's why you can't use blood. And I explained to people when I'm discussing this is like watching the freeway does not tell you who's in the parking lot. You know, if it's a really great football game or a basketball or whatever the event is, you might see a few cars going by for several hours and end up with a stadium just completely full of people and cars. So watching the freeway or the blood system doesn't tell you anything about the parking lot. And the parking lot's called the body burden, and that's the one that Mike was talking about today with the DMS at challenge that shows there's a lot in the parking lot. So a little traffic every day ends up with lots of people in the parking lot. David Eggleston showed, and I call this the LA County roadkill study. He did it, well, it's scientific term, isn't it? Very interesting study, because, you know, like as Dr. Tylenda kept saying, you know, what we used to think in the academy was what we needed was more data. You know, what I think we need is more thinking. But David Eggleston has been active in the area of research for a number of years, and he was the fellow that showed the T cell drop and so forth. And they said, well, you didn't do it on enough people. Well, now how about 100 people? So what he did is he went down to the LA County coroner and he said, you know, I'd like a piece of the brain of about 100, 200 people. And the coroner said, sure, fine, no problem. We'll just make it a normal part of autopsy. So if in the year that they did that study, if you happen to get killed in Los Angeles, you know, by a policeman or for a parking ticket, shot, or, you know, murdered or something like that, as long as you get shot in the head, that you ended up down at the coroner's office. And that they would give David Eggleston a ring, and he'd jump in his car and race over there with his dental assistant, and he developed a real scientific way of taking a sample. He'd take his saliva ejector, you know, the big round high volume evacuation tube, and the surgeon would lift off the top of the occipital lobe, and he'd poke that tube in there and say, thank you, bye. And so he had a little chunk of brain. And what he found was that in the occipital lobe, remember the study I showed you just a second ago on the dog? The occipital lobe was the furthest from the exposure. The dog has a big long nose, kind of like some of us. And that most of the mercury ended up in the front part of the brain. Dave knew that. And so he went as far away from that exposure as he could, as far away from the teeth as he could, clear back to the occipital lobe, thinking, I'm going to get way away so I won't have that contamination of my sample. Even at that, people who had amalgams in their teeth had 2 or 3 times more mercury in the brain than people who didn't. Now, I can argue with that study. 100 people in the study, large control group. We have a large, you know, like we lost in Vietnam and they all came here. Well, we have a lot of people in LA that have little or no access to health care and have never had a filling in their lives. He said finding the cavity-free controls was no problem. He says we've done a real good job of stopping tooth decay. So obviously, the mercury's getting out of the teeth into the brain anyway. But symptoms of mercury poisoning can be divided into a number of different categories. How you divide them doesn't make much difference, but And just for the purpose of looking at them a little bit and kind of seeing, as we were playing around after the lecture yesterday evening, one of the things that has been identified as a common symptom among dentists that have high exposure is tremor upon load. Is that, you may be, I've had old dentists, say, well, look how steady I am. And I said, well, yeah, put a little pressure on it. And they go like that. And I said, well, no point in pressure under load means when you try to lift something, if you shake, that the innervation of the muscle isn't steady enough or strong enough to hold that. So as the nerve becomes poisoned, the strength of the signal from your brain to the arm is delayed, missing, or interfered with. And in a study of dentists who had fairly high exposure, they found that they had delayed nerve conduction from their brain to their arm. When they actually measured how long it took us, an impulse they did electronically, they'd stimulate one end of the nerve and see how long it took to get to the other end. It took longer for it to get from the stimulation to the end of the arm than it did a non-exposed individual. And so these are some of the symptoms that you can look at. Excitability, no, I'm not excited. I just have a good time. Anyway, the memory loss, insomnia, depression, irritability, shyness, and confusion. Well, at least I don't suffer from one of those. What was it I was going to say? Anyway, I had a dental assistant that came to work for me a few years ago, and she asked me, said, how do you respond to stress? And I said, terrible, I leave. And they said, no, I mean, like, if I'm not real good, like if I forget what you're going to use next. And I said, well, I usually have you write it down and take notes, because I don't like to remind you all the time, but I'll do it 10 or 20 times. But after that, I'll ask you to go home and memorize it and tell me what I'm going to use next. And she said, well, I understand that. And I said, why do you ask? And she said, oh, the other guy I worked for, he used to throw instruments at me. He's not excitable, no. But anyway, so maybe she had a little memory loss. Advanced symptoms are ataxia, which means you can't walk real good, similar to Parkinson's. Foot slapping gait, it's been described as. You can often hear it in the halls of dental schools. Delayed reflex, we've talked a little bit about that, but that means that that your foot doesn't get from the accelerator to the brake pedal quite as fast. It's considered a normal process of aging, but basically what happens to dentists is all that's accelerated. That the normal process becomes in the space of 10, 20 years in your profession. Visual disturbances, if you go to the dental meeting, you can buy all kinds of magnifiers and loops, and as Rich Fisher was saying the other day, that he wondered if myopia was a religion, and I think you start out as a myopic, then you become a presbyopic. But visual disturbances, as Ben Lane pointed out at one of our academy meetings in '87 in New York, is that the growth of cataracts is absolutely associated with exposure to mercury in fish and humans. So speech disorders, I don't know anything about that. Especially in children, like the dyslexic ones that can't get the words right. The dyslexic reorder. The oral symptoms, Mike went through fairly thoroughly earlier, but have you ever had a patient come in with bleeding gums? Like, excuse me, but we're talking 90% of the world, excess salivation, metallic taste, loosening of the teeth, and burning mouth. As I pointed out the other day when we were over talking to the senators and the congressmen, that 90% of adult tooth loss is because of gum disease. And we can demonstrate a millimeter and a half of bone loss around the tooth that's got an amalgam filling in it, and that's 30-year-old research. So when they say there are no proven adverse physiological effects, I guess they must not consider losing your teeth an adverse physiological effect. That's all I can figure. The type 3 allergic reaction, chronic atrophic dermatitis. Now, there's some misinformation about dentists, and one of the things is that there are no adverse effects of being a dentist because you live as long as the average person, and that I know many of you were aware the other evening, as I pointed out, that a dentist is hardly an average person because in order to be average, you'd have to be graduating from dental school to be compared to a dentist, or at least be a graduate of 4 years of postgraduate study. And an infant generally is not born with a certificate or diploma. So comparing a newborn American, saying a newborn American lives as long as the average dentist, is really a facetious epidemiological study. It would never get published anywhere except in a dental journal. I know you like that, but the problem is that you got to pair dentists up with somebody that is social equal. So you know, if you look at proctologists, we're about 7 years short. You got to get through all of those things that kill kids. You know, the measles, the mumps, the car wrecks, and the suicide. You know, more kids kill themselves before 16 than die in car wrecks. But as soon as they get their driver's license, more kids kill themselves in car wrecks. So, well, at least they're not killing themselves anymore. They go out and drive around. So, what they've been saying for a long time is dentists live as long as the average person. Well, excuse me, that's not a logical thing. But the other thing, chronic dermatitis, many dentists lose the ability to practice dentistry because they can't wear gloves. They can't use soap. They can't handle acrylics. They can't use the materials that we've used because of the allergic reactions that they develop to those materials. Well, those people don't show up in the statistics because they're no longer in the survey. They drop out of the ADA and they go out and get a job selling real estate. So these surveys are facetious on their face because they're using dentists that are still in practice. So the dentists that are disabled are no longer considered. They don't go back and take the graduating class of 1972 and see how many of them are still alive and working and well. They look at practicing dentists. Oral lichen planus, definitely associated with an allergic reaction to fillings. I got this in the mail in 1979, and what they were threatening me. I still got the pamphlet. I kind of enjoyed it. They said, you really need to sign up on this urine study by the ADA because once the symptoms develop, they're scarcely noticeable. But you know, when they get real bad, they don't go away. So you better sign up today and send us $175 or something like that to be on our urine study. And then you would take urine and put it in a jar and send it through the mail to be tested some weeks later. Well, if you want to make mercury leave something, don't preserve it. It'll go. So if I'd participated in that study, I'd be part of their erroneous results. Percentage of the population allergic, a number of people, the ADA contends in 1977, I think they said it was 5% of the population. And then in 1984, they decided it was 1%. And then Enid Neidl recently said we lied. It wasn't 1%. It must have been much, much less. Well, I think she's right about one part of that. Anyway, White and Brandt showed a stair-step relationship between your first year of dental school and your last year. So where is the informed consent? It says, oh, by the way, signing up to become a dentist, we will alter your immune system to make you allergic to the materials that you'll be implanting in your patients. Well, in California, I bet they'd like a couple of those. So that was 1976, and that was early in the dentistry. I don't know if you, I sometimes read books other than dental, and that what we're in is that the post-industrial revolution is that the industrial revolution is when we learned to do fillings faster. Then we got the high-speed drill and all that stuff. We got multiple operatories and started using assistants. That's called the post-industrial revolution era. And so what happened about 1957 is they got a high-speed drill. And so then instead of a few fillings a day, we got to do 20, 30, 40, 50, 100 fillings. And so what happens is that each succeeding generation of Americans has more mercury in their teeth. And that's one of the reasons we see problems today, Dr. Kennedy's opinion, that we didn't see before, plus the bioaccumulation. Miller et al., 10 years later, wasn't able to duplicate the White study at the same university. And what he found was that the freshmen were just as allergic as the seniors, and they were all using the same technique. They were all a lot more allergic than they used to be. So he took his data and cranked it another way, and those people that only had a few amalgams were less allergic than those people that had a lot of amalgams. And so he could show a nice correlation between the number of fillings in their teeth and the amount of allergy. So this is another compiled slide for you, and that there's a number of different studies that have looked at this. And the thing I like best about this slide is that if you put all their controls together and look at every single control in all these studies, if they had no mercury in their teeth, they didn't test allergic to it. And if they had mercury fillings in their teeth, a percentage, somewhere in the neighborhood of 15, 16, somewhere in that neighborhood, tested allergic to it. So when people say there are no adverse effects ever documented, that, you know, if you add the total number of people in these studies up, you've got a fairly substantial bolus of information that can be ignored by the most blind people in the world with little difficulty. And so Jurassi and Barova, who did one of the studies, says it seems justifiable to conclude that both the latent and the manifest allergies are related to amalgam restorations. This conclusion is also supported by the fact that there were no positive reactions in their control group. So these were criticized as saying, oh, you must have burnt them, you must have scratched them, it must have been the way that they tested them, because you guys are only allergists, you don't know how to do this right. They weren't done by dentists. The other studies I showed you were. No, this is done by allergists. So if they scratched people with amalgams, how come they didn't scratch people without? So they had a real nice controlled study. So at least, and that's 1969. That was back when they used to estimate it was 5%. Now they're estimating it's 1%. They've done no additional study. So let's look a little bit at our personnel. We might want to look at kidney dysfunctions. We might want to look at brain tumors, but then they're too ghastly, so I don't think I want to. And then infertility, birth defects. The target organs, there's really no question that for some reason, and we're not really certain why, the pituitary sucks up mercury like a sponge. And that the kidneys, it's their responsibility to help the body get rid of about 10-20% of the burden. And that Dr. Benby very nicely showed that that doesn't do anything real good to the kidneys. And then reproduction is one of the more sensitive monitors of heavy exposure. This is a slide that I prepared from Dr. Nylander's study, and it's the amount of mercury per gram of tissue. It was published in 1986, and he apologized. It's real difficult to get human material in Sweden. Almost everybody's cremated. So and he's at the Karolinska Institute, and that he had to scuffle pretty hard to get seven people for his study, but he had real nice consistent results, so he thought it was worth making a report. And that if you look at the eighth person, clear over there on the right for the controls, I want to point out that the left-hand side of this is a log scale. And the reason I had to do a log scale is because we'd have to raise the roof of the hotel in order to show you the top of the peak if I hadn't used a log scale. And that since the carpenters weren't around to do that, we decided to shrink the craft. So controls were coming in with micrograms per gram wet weight of tissue in the 10, 12 range. And the light blue is the area of the brain. The dark blue is the pituitary. And so you can see that the pituitary is much higher than brain. And that becomes significant in just a minute. Number 8 is an assistant. It was not a dentist. There were 7 dentists, and the example number 8 over there was an assistant that he managed to get into his study. So you can see that there's a fairly large disparity. He also went on to show in the Eggleston study that pattern of excessive mercury in the pituitary also followed through in ordinary people, but at a much lower level. Kidney dysfunction in the study of kidneys, the only paper that I found on it compared them to cadmium workers. Cadmium is notorious as a nephrotoxic substance. It gets in there, it doesn't leave, it's real damaging to kidneys. So OSHA for a long time has been looking at the kidneys of people that are handling cadmium. And what this paper is, well, cadmium's so bad, let's compare these workers to dentists. And what they said is, therefore, the dentists and dental assistants appear to have a higher potential risk of kidney function disturbances than the workers in the cadmium industries. So we're a little worse than the smelters, and the OSHA's been regulating the smelters and the people handling cadmium for years and years and years, and they didn't even realize that the dentists were exposing women of childbearing age to levels of mercury that are completely unacceptable by anybody's standard. Were they able to do that with impunity? Was there no problem? Nothing happened because of that? Well, the proponents of the use of this toxic material would insist that we couldn't prove that exposing our staff and our assistant and everybody within 20 feet of our operatory to levels that were considered grossly unacceptable by all the, I hate to use the word civilized because it doesn't seem to apply, but all the industrialized, there we go, there's industrialized countries of the world, could be without some adverse side effect. So Mironova et al. Looked at menstrual function, and that, as I showed you, the pituitary sucks up the mercury kind of like a sponge. Pituitary controls menstrual function. And what he found was that there was either excess flow or minimal flow, and somewhere in the neighborhood of 40% of the people exposed to mercury. What's interesting is it was like in 0.7% of the people that were not in his control. So yeah, that does kind of screw up the way that works. Gordon presented this information in 1981 in Scotland, and after a fairly extensive study of female dentists and dental assistants, and he compared them to medical personnel, and figuring that a woman dentist would have a fairly good knowledge of health care, would know how to take care of herself, adequate nutrition, earned a fairly good salary, so she would not be economically depressed. Who would be her social equal? A similar medical person. And so he used what are called paired controls in a nice study, and what he was able to show was that the 3 times the increase in spontaneous abortion or miscarriage occurred in the women dentists, and it was not in the female medical personnel. What's also interesting, the only group in England where the study was done that had a similar rate of spontaneous abortion were the homeless. So you might, when they say, well, we can do this with impunity, well, yeah, we don't mind losing a few kids. And Dr. Vimy showed, and this is a repeat for you, that mercury from the fillings was spread throughout the sheep's body. The blood levels were not related at all to the body burden, and it accumulated in the fetus to levels in some organs that were higher than the mother. And the milk level was 8 times greater than the sheep's blood, and that because milk is a filtrate of the blood. The United States Environmental Protection Agency has stated on several occasions that women chronically exposed to mercury vapor experience increased frequencies of menstrual disturbances and spontaneous abortion. Also, a higher perinatal mortality. We've got a big drive going on in the United States to try to help the infant live through the first year of life, because our perinatal mortality is one of the highest in the world. Nah, that's not true. Our perinatal mortality is one of the highest of the industrialized countries. And you can get a higher perinatal mortality if you're dropping the kid on the ground and letting him walk. But for countries that are supposedly advanced in their medical care, we have a very high perinatal mortality. I should do a slide there and show you what we look like compared to a lot of other countries. The ADA did a sample of 1,555 dentists at meetings, and what they found was that the blood level was 8.8 nanograms per gram, and this was at a mean level, urinary level of 14.2 micrograms per milliliter, ranging from 0 to 556. Now, if I had my choice, I'd rather be the 0. But the lady debating down there in Rio used a graph of this particular study, which had something like, I forgot, I think it's 12% of the dentists fell into the, like above 100 micrograms. So, it depends on how you look at it. If you look at the mean urinary level, that takes this 0 and averages in with the 555, and you come up with 14. See, that's not a problem. Well, it's not a problem unless you're 556. And so what she showed on her slide actually was that we were poisoning ourselves. And sometimes people say, well, these dentists, they're really bad people, they're putting these poison materials in there. And I said, well, yeah, they're really bad people, but since they're standing right beside the person they're poisoning and doing it day in and day out, I have to say maybe they're a little stupid too. So, or misled. And that I particularly like putting on this presentation with a dental instructor, because I could go through with what my instructor told me when I was in dental school, is that there really wasn't a problem with exposing yourself to this mercury because it was known to be safe, and that it was locked in the filling when you mixed it up, and blah, 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 blah. And I said that if it's locked in the filling, what is this dentist doing over here, this 555 micrograms, which everybody agrees is a horrible level. She didn't have a lot of explanations on that, but she didn't like this one either, because that took her data that she'd shown as a bar graph with means and averages and so forth that took the spikes and peaks out of there. And that our US EPA has decided that 20 micrograms was not a helpful level. I'd rather be 1 or 2, but 20 was where they really said, no, you're kind of in trouble here. And so if you take that data and you crank it a different way, what you see is that there's a fairly big chunk of that wedge of dentists and dental personnel that come out as having exposed themselves to excessive levels. And so over 20, over 30, that's micrograms per milliliter, over 50, over 100. Over 100, everybody in that category is poisoned by, because remember, you can only eat 10 in a total of 30, and the urine's only responsible for 10 or 20%, so you can't get 100 out if you're only eating 10. It's just like a bank account. You can't use your ATM card to withdraw 1,000 if you only deposit 100.
Unless you're a senator.
Oh, I forgot that. Mark's right. I forgot. Maybe I'll run for office. Take those bounce checks off. And what Gordon showed was that in terms of population, the perinatal mortality was 19.5 among the dentists, and it was that's higher than the average American perinatal mortality quite far. There was interesting. They had some data on the American dentists, but the people that collected it say they lost it, which is a shame. And I think 1,600 people responded. Brain damage, yeah, it happens. Twice the incidence of brain tumors has been identified as a problem of being a dentist or a dental assistant in Sweden. They did that study real easy. They just collected out of the tumor registry in Sweden, said, what do these folks die of? And if they were a dentist, and they said, oh, brain tumors. Twice the frequency with which an ordinary person in Sweden died. Tremor, nicely documented. All those people that have the 50 micrograms or greater are going to shake if you put their arm under a load. Got a quick story for you. Many of you know Betty, and not one to mince words either. And she went into a coffee shop in San Diego not too long ago and had a little cup of coffee while she was waiting for the transaction to transpire. And a gentleman came breezing in his white coat. And they said, hi, Doc, how you doing today? Say, you gave us a bunch of pesos the other day to hold for you. You said you were going to buy them back. He said, I did? He said, yeah, you gave me this big wad of pesos. Oh, yeah? How much is it? That's $15 worth. He said, oh, I'll buy those back from you. And he said, I'd like a cup of coffee. And he got him a cup of coffee, and he said, well, that'll be $2. And he says, oh, I forgot my wallet. And he said, well, we'll put it on your tab, Doc. And he turned around to Betty, he said, I bet you're a dentist, aren't you? And he says, yeah, how'd you know? He seemed to forget quite a few things. He says, yeah, I think I'm Mercury poisoning. So, the exposure prevention. How'd you know? The exposure prevention, we're told not to touch it. Now, I like this, because what do we do to the patients? Huh? Okay, I'll go to work for the filling, Doc, but don't touch that. Yeah. Don't breathe in either, because you can't breathe the fumes off of it. Because Dr. Tylenda said there's low levels of mercury around there, so you got to breathe it out around that tooth all the time, so you don't bother to breathe in off the top of it. So, and then, where are the urine studies? Urine studies that we're supposed to regularly do to make sure we don't expose ourselves and our personnel, and urine doesn't make any difference anyway. We're not supposed to have women of childbearing age at the chair side exposing to high levels of mercury. Why not? Because it affects, Wayne, toss me your mask. It affects the fetus. And that one of our academy members went to the trouble to figure out what kind of mask it's going to take to cut down your exposure. And it's looking right here. This is what a miner wears, because of the mercury that's coming out of, and that if you wear something like this and keep your office clean, you can cut the exposure of yourself and your staff. I still don't recommend you have pregnant women working at the chair, but if you're going to be taking amalgams out or using mercury, you should get your exposure down with your technique and with this, because you can't use this material with impunity. There are problems with it, and they're nicely documented in scientific literature. So, I think that's my last slide. Yeah.
What's the projected legal ramifications if your chairside assistant gets pregnant?
Depends on whether she's married to an attorney or not. In California, you might as well just go ahead and leave in your car in your house. In the other states, you might be able to argue you couldn't prove I did it. The Academy has developed a protocol for safe amalgam removal. We don't have a lot of time to go through that. But one of the things that's really clear from all of this data, that we're not handling a safe substance, and that you've got to protect your staff with something that works. You've got to protect the patient during the removal process. Many people get this stuff removed and get worse. Why? Well, I showed you the 2,000 micrograms. We had a guy speak to our academy that was badly poisoned by this. So protect the airway. They'll get their exposure primarily through their nose from inhaling the fumes. Wash the field continuously with cold water. Turn the heater off in your unit. Use lots of water out of your drill. A lot of people cut the water down on their drill so they can see better. Turn it up so you're blind. Well, I guess just during the part where you're cutting the filling in half. And we use what's called a cut and chunk removal technique. You cut the filling in half, you cave the pieces in, and suck them up in the vacuum. If you leave the vacuum beside the filling all the time, I've got a Jerome 411, I can keep the numbers to 0 within about 12 inches of the patient. I also use a plastic drape on the patient so that the little particles that might escape don't land in their clothing and they carry them home, get in the washer, get caught in the other clothing. Some people are excruciatingly sensitive to stuff, so we try to keep the place real clean. That's the Academy protocol that's been approved at this point. We're asking for submissions for additional protocols. If you submit something, send the documented scientific evidence with it, not just the reference, the real paper. And that Phil Sukel is in charge of that protocol. And we've got a number of other things that have conditional approval that are adjuncts to patient detoxification and therapy. But the Academy is going to speak on this subject in greater detail as we collect more data about the safe way to get these toxic mounds out. I thank you for your kind attention, and we've got to kind of wrap it up so we leave some room for Bill. And I have some leftover halcyon if anybody wants to.
Here's monitors and bags.
Why don't we take about a 10-minute break, get a little coffee or tea, and we'll start back.
Yeah. By the way, this is the monitor badge that you can wear if you still want to pack amalgam or if you want to remove amalgam. These little badges you can hook them to your clothing and wear them around, send them in for recycling. That's the vacuum filter. Yeah. Winged. It's got several. Get one. Actually, they're not bad. They put one of these in each room. Yeah, of course. They want you to. I'm real reluctant. You know, they got to show me that works for it. Or they got to catch me polluting the environment. I read the FDA thing about the halcyon. Must have missed it. He flew to Japan. We got there after a long flight work and he laughed. So the doctor that flies with him says, well, after this little halcyon, you can go ahead and take a nap and get you up. So we had our 4 hours and we're going to dinner with the prime minister.